I've been asked to discuss few issues relating what impact this COVID-19 pandemic has had on the practice and outcomes of surgery and non-surgical interventions. Well, there's no denying the fact that this pandemic is a clear and present danger to the entire world, and it has impacted all aspects of clinical practice, not just in India, not just in a few countries, but globally. And this impact is felt more on surgical and non-surgical interventional practices, because these are interventions or procedures which are perceived to be of greater degree of danger to the healthcare workers and for transmission of infection. The pandemic has indeed brought a change to the perceptions, how surgeons and other interventionists see our practices. It has forced a change in the protocols that we are practicing or are following today, and it has resulted in some definite change in our practices and seems to have changed or altered the performance or the outcomes of surgeons and other interventionists. What is guiding the practice and policies for surgeons and other people who are practicing interventions? Well, we all believe, or at least we tend to believe, that we practice based on solid scientific evidence. We practice evidence-based medicine. But in this era where everything has happened in such a short span of time, there are so many uncertainties. Unfortunately, we are forced to practice based on our intuition and our beliefs more than based on solid scientific data. The available evidence, though meager, it all relates to some prospective and many retrospective cohort studies. And in recent couple of months, there have been a few rather small systematic reviews and meta-analysis. But by and large, how we practice is based on the expert views, and which also reflect in the guidances provided by many international and national scientific societies or professional societies. So in absence of solid prospective scientific evidence, it makes sense to be logical, and the logic says that in such times of uncertainties, we follow this kind of an approach where we plan, we do certain things, and then we check again and act or adjust according to what we found in our initial practice or the results of the initial practice. It seems very logical that we be selective and judicious in offering surgery or interventions to patients who are at greatest need for them and who are at an urgent need for them. As much as possible, we can avoid or postpone or delay the surgery or interventions until it is a safer time. More and more, we are using non-operative or non-intervention alternatives where they exist, unless, of course, the surgery or intervention itself is perceived to be life-saving. There are a number of examples where alternative strategies have worked well, and I'm just using one of those examples. Early stage breast cancers, which are hormone receptor positive, or in other words, hormone responsive, they had been conventionally treated with primary surgery first, followed by adjuvant treatment. However, in this time of pandemic, globally, we have changed our practice. Patients are put on neoadjuvant or preoperative hormone treatment, and it makes good sense because it gives you time to postpone the surgery until the pandemic is over, or it is at least somewhat contained. And a question that is often asked, whether this postponement of surgery, would it have an impact on the survival of these patients? And then a paper which is about to come or is on the website of Journal of American College of Surgeons now, it very clearly shows that by delaying surgery by up to 120 days, we are not impairing the survival chances of these early stage breast cancers. So in the current era, we need to find a fine balance between the risk of adverse events or adverse outcomes related to delay in treatment or delay of surgery and interventions, and so compromise disease control, versus the risk of death or serious morbidity on account of COVID, both for the patient and to the health systems or healthcare workers. Of course, it also makes sense to mention that one must operate or intervene where one has to, where the disease is such that if we delay it further, it may cause serious harm to the patient's life. And wherever such a intervention or operation is planned, it has to be done with full preparedness to minimize the risk of COVID infection, both to the patient and for the healthcare workers or their adverse outcomes. So a central point to this whole scheme of practice today is assigning risk to individual patients. The patients may be confirmed cases of COVID infection on one hand of the spectrum, or they may be tested and found negative on the other hand of the spectrum, but there would be quite a few patients who are either probable cases or suspected cases, cases where either the disease has not given you a sufficient time to test for COVID infection, or the test has been done, but it has either been equivocal, or even though the test report results may be negative, but the clinical index of suspicion is so high that you would like to consider the false negative part of, or false negative results of COVID testing. Something which Dr. Rajneesh has touched upon, wherever you're in planning surgery or interventions, these are considered aerosol generating procedures at highest possible risk of transmission of infection. So these people who are indulging or who are participating in the surgery or interventions need to have the highest level of protection in terms of personal protective equipment and masks or respirators, and I will not elaborate it further. So here on, I would discuss certain specific issues relating surgical practice and how it has been impacted by COVID-19 pandemic and the outcomes of surgery, and also touch upon briefly on how cardiac interventions and GI endoscopy or interventions have been impacted by the COVID pandemic. And I would like to acknowledge my friends Dr. Aditya Kapoor and Dr. Sameer Mahindra for helping me with this part of the presentation. Well, as far as surgery is concerned, there are a number of societies, global, international, national, which have brought about guidances and guidelines about relating how surgical care has to be imparted during the pandemic. While they may vary to some extent, but there are a number of commonalities, and all of them have brought out specific guidances regarding how we need to triage patients, what kind of pre-admission and pre-operative or pre-intervention considerations are required, and then of course the perioperative and post-operative considerations. One must categorize patients into non-infected, potentially infected, and definitely infected groups because the three groups require somewhat different approach. All patients must be tested for COVID today because there is a certain risk, a definite risk involved in operating or intervening in patients who are COVID positive, unless the disease, the condition that you're treating is life-threatening and it precludes RT-PCR testing or COVID testing. One must have a dedicated operating system, operating room, pre and post-operative anesthetic and then care areas for patients who are COVID infected, and these patients must be isolated from non-COVID patients, and the counseling and consenting in these patients who are COVID positive or probably positive, that has to be specific. Even for patients who are COVID negative, they must be informed and have to be consented for somewhat higher risk than usual in terms of pulmonary complications and other adverse outcomes. In terms of how we manage the patients perioperatively, before we operate, one must prepare and train the healthcare workers and the entire health system for various specific tasks that they have to undertake, including for appropriate usage of PPEs or the personal protective equipment and respirator masks. One must minimize the number of staff in the operating rooms. Operating rooms themselves have to be prepared appropriately. Ideally, there should be negative pressure rooms with minimal essential equipment inside. During surgery, one must try and minimize or contain the aerosol generation, either, for example, by using video laryngoscope and containment boxes and using appropriate filters in the anesthetic circuits. Appropriate PPEs and mask respirators are essential for all participants in the surgery. Use of smoke evacuators and judicious or minimal use of certain techniques and technologies which may put a patient at a high risk of COVID infection should be minimized. Post-operatively, patients who are infected or potentially infected must be isolated. They must be monitored for COVID infection or unknown, even if they are negative or unknown for COVID. And specific protocols for decontamination and sanitizations must be practiced universally. Okay. In terms of outcomes of surgery in patients who have COVID infection, the first question that comes to mind is whether patients who have COVID infection, they are at a higher risk of death or serious morbidity. So there is some data available. This study from Italy, it reported a matched cohort of 41 patients with COVID infection with a control group of 82 patients who were COVID negative, and the 30-day mortality and serious complications were significantly higher in patients who were COVID positive or infected compared to those who were COVID negative. Another question comes to mind is whether it is important to test all patients for COVID infection before operating. This review done by investigators from Israel, published in World Journal of Surgery, used 6 studies which pooled 64 patients, and the mortality rates of such patients who were operated during the presumed incubation period for COVID was definitely much higher at 27.5%, which is unacceptably high. And these patients had severe pulmonary complications, and it also resulted in serious exposure of the staff and infection transmission. So it does recommend screening for COVID infection for all patients who may be asymptomatic for COVID prior to surgery. COVID Surge Collaborative is a major collaborative effort led by investigators from University of Birmingham. And in this international multi-center cohort study published by the COVID Surge Collaborative, which included data from 235 hospitals in 24 countries, they looked at what was the risk of death within 30 days following surgery in patients who had COVID infection, also looked at the risk of pulmonary complications defined as pneumonia and ARDS. And in this study, a total of 1,128 patients were included, and about 24% of them died, which is definitely much higher than perioperative mortality in any era. Of these patients, roughly about 3/4 of them underwent emergency surgery, and these patients who had emergency surgery had much higher mortality rates as compared to those who had elective surgery. The predictors for 30-day mortality were age more than 70 years, male gender, ASA grade 3 to 5, multiple comorbidities, surgery for cancer, emergency surgery, and major surgery vis-a-vis minor surgery. So in these patients, pulmonary complications were the major cause for mortality. In all, 24% of patients died. Mortality rates were higher in patients who had pulmonary complications. This mortality rate was 40%, and serious pneumonia and ARDS were the causes. While we are now unlocking it, the question that whether elective surgery should be started and is it safe, this question is answered in some small studies, including this one, which reported 621 consecutive cancer patients who underwent elective surgery. None of them died, and this is pretty much the kind of experience we have had here as well. Very briefly, how has COVID impacted the cardiac interventions? It has indeed impacted and raised a number of questions, which have led to even questions being asked in popular media and in newspapers. Where have all the heart attacks gone? It seems that the number of serious heart attacks or cardiac illnesses have gone down significantly. There's a definite reduction in intervention procedures, and there's a shift towards acute procedures only and deferment of elective procedures. Intervention in cases of acute coronary syndrome is being done only after very serious risk stratification. And where it seems that when properly risk stratified and managed accordingly, patients who have COVID-19 infection, they have similar outcomes as compared to patients who were treated prior to the pandemic. And in interest of time, I would skip much of these details, but there is data from US, from Spain, and other networks which suggests that the number of patients being intervened or undergoing PCIs is much lesser today. There are guidances from American Society, from the European Society of Cardiology, which provide specific guidances regarding how to manage ST elevated MIs and non-ST elevated MIs. And there is data to suggest that in patients who are carefully selected and risk stratified, the outcomes are similar to the earlier era. And in the end, how has COVID-19 pandemic impacted the practice and outcomes or interventions of GI endoscopy? There are a number of polls or surveys which have been done internationally and in various countries, including India, and more or less all of them, they suggest that there's a substantial reduction in number of GI endoscopy procedures being performed all across the globe. These cancellations or reduction in emergency as well as elective endoscopy procedures, they may be impacting the outcomes for approximately a quarter of all patients. All these surveys, they underscore the importance of appropriate PPEs for the whole endoscopy team, importance of room sterilization and pre-procedure screening for all patients. There is a certain big risk of infection transmission to patients as well as healthcare workers, which has been brought about by these surveys. There seems to be a rather low risk of transmission, as has been brought about by two case series from northern Italy, and that these data suggest that GI endoscopy is relatively safe both for the patient and healthcare workers when adequate protective measures are used. So to summarize, the COVID-19 pandemic has impacted the practice and outcomes of surgery and non-surgical interventions. The interventions must be, they can result in serious adverse events for the patients as well as for the healthcare workers. Interventions must be selective. One needs to find the balance between managing the disease burden and adequately managing the outcomes, and on the other hand, reducing the risk to the patients and the healthcare workers. If only essential, patients must be operated or intervened with full preparedness. The 30-day mortality rates are higher in patients who are COVID-19 infected because of serious pulmonary morbidity and complications. And the predictors are, as I discussed earlier, all patients must be screened for COVID-19 infection before undergoing elective surgery or wherever possible, because there is a higher mortality and pulmonary morbidity in patients who manifest with COVID-19 post-operatively, or in other words, these are patients who may be operated during the incubation period of COVID-19. Thank you.